My name's Claire Wood. I'm with the University of Missouri St. Louis, Missouri Institute of Mental Health, and today I'm going to be presenting on racial inequities in treatment retention evidence through the implementation of Missouri's state targeted and state opioid response grants. And I'll refer to these throughout the presentation as STR and SOR. I do want to note that we have no conflicts of interest to disclose. As a refresher, the MedFirst approach was developed through the SAMHSA-funded STR grant back in 2017. The goal of this model was to incentivize Missouri's publicly funded OUD treatment providers to approach OUD treatment from a chronic care model and reduce barriers to accessing medications. The four principles essentially that clients should get medication as quickly as possible, be able to use it for as long as it's working and unless something goes wrong, and without requiring participation in other services. This was a paradigm shift for how OUD treatment had traditionally been provided in Missouri's publicly funded system. The key takeaways from our initial evaluation, which again, these were statewide evaluation results, were that individuals enrolled in STR were more likely to receive medication driven by the increased utilization of buprenorphine, get medication sooner, receive fewer psychosocial services, and be engaged at treatment at 1, 3, 6, and 9 months. Even though we were seeing improvements in treatment outcomes for people in STR, when you look at the overdose deaths in Missouri, particularly broken down by race and sex, we were seeing massive inequities. Black males in Missouri are the most affected by overdose death, and if you look at 2019, Black males were more than 3 times as likely to experience an overdose death relative to white males, white females, and Black females. I do want to highlight that St. Louis City and St. Louis County, these two counties highlighted in red, were the major drivers of the statewide racial inequities we're seeing in overdose deaths. So 86% of the overdose deaths among Black individuals in Missouri occurred in these two counties. And I provided a little bit more information here about the population as well, but I'm not going to cover that for the sake of time. Our research questions were driven by seeing these racial inequities in overdose deaths. So we asked, were white and Black people with OUD equally likely to be served during STR-SOR compared to the year prior, receive buprenorphine, and be retained by treatment providers at 1, 3, 6, and 9 months? The methods we used included 3 years of data. The first year was the year prior to STR, which I'll also refer to as pre-STR, the first year of STR, and then the second year of STR, which also overlapped with the beginning of SOR. The data source included state billing or claims records, and we defined things using treatment episodes, which really relied on the first billable service through when the treatment episode was closed out. The population included uninsured individuals with opioid use disorder because that was the target of the state targeted and state opioid response grants. And then again, we focused specifically on the St. Louis region because that is what is driving that inequity and overdose deaths statewide. When looking at treatment admissions by race, during the first year of STR, reflected by the middle orange and blue bars, the proportions of white people served went up, whereas the proportions of Black individuals served went down. However, this went back to baseline during the second year of STR. And looking at buprenorphine utilization, there were no significant differences across race or across any of these time points. I do want to note that this is a little different than what we found in looking at buprenorphine utilization statewide. So it does appear that the MedFirst model didn't have as big a the MedFirst approach did not have as big of an impact on increasing the utilization of buprenorphine in the St. Louis area. I do want to note, though, that this is people who only received buprenorphine and not any of the other medications in their treatment episode. Treatment retention, though, this is where we see a major impact. So you can see here this gray line at the top is the treatment retention among white individuals during that first year of STR. And you can see the treatment retention for these folks increased at each of the time points, but we see really minor and relatively few differences for any of the other groups. So this means that during STR there was a disparity in retention between Black and white individuals that hadn't been there prior and wasn't there in subsequent years as well. Let's discuss these results. So first, why did the racial breakdown of treatment admissions change during the first year of STR only? We think this had a lot to do with how information spread about the availability of STR services. Essentially, we speculate that this was a first-come, first-served situation, and information about low-barrier buprenorphine traveled fast through local harm reduction and overdose prevention circles, which are predominantly white in the St. Louis area. Through our lack of centering racial equity, we contributed to the inequitable access to STR services. Why were treatment providers able to improve retention to a greater extent among white individuals than Black individuals? The first thing I want to highlight is that this is not about a person's individual willingness to engage in treatment. Systemic oppression creates a number of external and treatment setting factors that have undoubtedly played a role in these inequitable retention rates. It's possible that the Med-First model was inequitably implemented. So to the extent that less punitive approach to treatment was only applied to white clients, for example, not discharging clients for positive urine drug screens or no-shows. And there is research to suggest that this happens. Another possible explanation, likely operating in tandem, is the lack of culturally responsive treatment modalities and cultural humility among treatment providers. There are also external factors that we need to think about as well. A lot of the treatment providers in the St. Louis area are not in predominantly Black neighborhoods. Same with recovery housing. There is recent research, too, that shows that proximity to a bupe prescriber is linked with treatment retention. So not only that, there's less access to treatment and recovery housing for services for Black individuals in their neighborhoods. Transportation also plays a huge role, too, and Black individuals in St. Louis have less access to transportation than white individuals. So being far away and not able to get to your treatment program will lead to attrition to treatment. Finally, why was this pattern only evident in the first year of STR? Essentially, there was a budget crisis in the second year of STR, which led to providers being more cautious in their implementation of Med-First. And so all the benefits we saw from that first year of STR, which were really only afforded to white individuals, were vastly reduced in that second year. So how do we address these racial inequities? The first thing is being very intentional about how funding is allocated and ensuring that funding is dedicated to organizations and efforts that center racial equity in their work. This is something that has been done more consciously through SOR and SOR 2.0, but this is something that needs to be done on the front end of grants, programs, etc., and on a broader scale as well. We need to think about improving access and removing additional barriers to treatment and other services for Black individuals. This means services that are co-located in predominantly Black neighborhoods, removing transportation barriers by, for example, funding transportation services. And this is something STR actually did. Additionally, it's important to make sure that information about available services is intentionally disseminated. And finally, we need to identify what resources, support, and information is lacking in treatment environments to better serve Black individuals, and then address these gaps. This is going to take a lot of work from treatment providers to do some self-reflection and evaluation of their own processes and competencies as well. I want to highlight the importance of incorporating a racial equity lens up front. Some of the questions we've been asking ourselves since reviewing some of this data include: were providers expected or asked to do anything different in their programs as it relates to racial equity? And were providers equipped to take into consideration the systems of oppression and additional obstacles people of color face both within the treatment system and everyday life? And although providers were asked to create and implement a low-barrier medical model in their traditionally abstinence-based treatment programs, which was a big ask, it didn't involve efforts specific to racial equity. And that could be a contributing factor to why we're seeing these outcomes. And so I just want to close with, if there was little or no intentional effort made to center racial equity up front, why would equitable outcomes be an expectation? Thanks for listening to this presentation. I'll be around if you have questions. If you won't be at the question and answer portion, please feel free to reach out by email or check out our website, nomodeaths.org.